Welcome everyone to this webinar, this question and answer session on psychosocial aspects of the Ebola emergency and its response to it. My name's Dan Chisholm, and I am based at the Department of Mental Health and Substance Abuse at WHO. But I'm really here wearing a different hat, which is as one of the people involved in the Mental Health Innovation Network, and specifically its role in knowledge exchange in the area of innovations in global mental health. So I will be the moderator, along with my colleague Fami Hanna, also in the department and working on knowledge exchange aspects of the Mental Health Innovation Network. But we'd like to extend a warm welcome to you all, wherever you may be, and of course, especially to our expert questions. Over to you, Peter.
Okay, thanks. I hope everyone can hear me and that I don't speak too fast. I'm Peter Hughes. I'm a consultant psychiatrist in London, and I've been involved in quite a lot of international work over the past few years. With Sierra Leone, I had been to Sierra Leone in the past, and I was involved with the King's Sierra Leone link with the mental health side of that. So I'd been involved with that for about a year and a half or 2 years. So I was really happy to get the chance to go to Sierra Leone with WHO, particularly as my trip with King's had been cancelled because of Ebola. And then I suddenly found myself going to King's going to Sierra Leone because of Ebola. So in my background, I have worked in international mental health work in the past. I've worked in disaster area before. I'm very involved in training and teaching. So before I went, I wasn't quite sure what was going to happen, as it is really a disaster area. I expected to be doing quite a bit of training. So it was a really wonderful experience, and I really thank all my colleagues in WHO and my colleagues in Sierra Leone for making this such a good experience for me, and hopefully fruitful as well. Describing what it was like, this was really in the planning phase in mental health when I was in Sierra Leone, along with my colleagues there. We were looking, I expected to be doing lots of training, and that did happen, but not immediately. What we found is a situation where we were really welcomed wherever we went in Sierra Leone. When we talked about being psychosocial people, everyone said, we really need this. This is really, really important. But it was quite frustrating matching that need to actually putting something in place. And that was beginning to happen as I actually left. So unfortunately, my time there was quite limited. So the sorts of things that we were doing, training was one thing. We were developing Ebola response, mental health Ebola response. We were doing some staff support work. We were really looking at the needs and what the future needs would be, which we were particularly looking at mental health for the future. We know that Sierra Leone is an extremely poor country. The mental health services and capacity is very low to start off with. And we absolutely saw that. So coming to Sierra Leone, I didn't really see so much of the mental health side, although we did visit the main secondary care units in Freetown, which are Kissy and City of Rest. But my role as a psychiatrist is really much broader. It was looking at being a psychosocial expert or specialist, looking at it in a much broader way. So I think that's kind of what I'd like to give for my background to start off with, and then perhaps if I start with the questions.
Yeah, thank you very much, Peter. That's a great introduction. Thanks a lot. So yeah, let's move to some of the questions that we had already received, and then we'll move to any other questions that they have. So, we've sort of slightly ordered it to give some kind of structure to the questions. And I think the first one that is a good place to start is just for you to try and outline what are the main psychosocial effects of Ebola on people in Sierra Leone and other affected countries. And then, based on that, what are the critical needs of those populations affected, and also what are the main challenges?
Okay, thanks. I'll take that. And I don't know if people have visual as well, so I have to excuse people if they see me drinking my cup of coffee. But I shall carry on now. So what are the main effects of Ebola? There isn't much written about the mental health effects of Ebola. There's quite a few papers from an anthropological point of view, which are really interesting, but don't tell you a lot of the mental health. After disasters, normally one expects an increase in mental health of populations, but I wasn't really seeing that when I went there. Going to the main psychiatric hospital, the number of admissions seems roughly similar to before so far. And there might be complex reasons before that. But the main needs are the main effects of Ebola are that people are terrified. They're absolutely terrified. They may be going around doing their normal activities. They may be meeting their families, but it's on the back of everyone's mind. And everyone you meet has a story. They have a story about people they've lost. They have, there's a lot of background to people's lives. With Ebola, you can't shake hands, you can't hug people. Even if a child comes near you, you move away because you are afraid to touch anyone. How that affects you is really hard to say, but there's a kind of a baseline severe anxiety, and there's anxiety. That's balanced against some of the kind of drives that are in Sierra Leone, like the burial drive, the importance of funerals, which are the most dangerous things of all. So, however anxious people are about Ebola, they still seem to do things that are really dangerous in parts of the burial rituals. There's Ebola affects people. When people get Ebola, obviously they're absolutely terrified. They think this is a death sentence. And it is, of course, a very lethal virus, as everyone knows. One of the things that was quite interesting was the neuropsychiatric effects of Ebola. With my role, I never had to go into a red area, but I did hear from people about the pathway of Ebola and how it affected people. For example, as people get more and more ill, they can become delirious, but they're not agitated. They become kind of quieter and calmer, even as they suffer and as they eventually die for those people. Other effects of the Ebola are the actual treatment, and we still don't know what effect this will have. Is when you're treating Ebola, you give someone such a huge fluid overload that their brain is swollen with fluid. It's cerebral edema, and we don't quite know how that might affect people long term either. Social effects of Ebola: there's no schools, there's no nightclubs, social things are closed. Just about the only thing that is staying open are the shops, but churches and mosques are open. Now I'll turn to what are the main needs. And this is a really difficult one because it's with such anxiety everywhere. It's how did you can actually deal with that anxiety on such a national level. I think it's about some of the ways you can deal with that are education. Public health is really, really important. And some simple messages like washing your hands properly saves your life. Not touching people saves your life. Having safe funerals saves your life. Simple messages that could really stop people dying. We took psychosocial in a very broad way. So we felt that psychosocial also includes the livelihood, having some money, having some shelter, having safe burials we considered as psychosocial need. So our psychosocial also we felt meant that if you've got Ebola in a treatment unit, that you get treated with respect, that you get called by your name, you get your food given to you in a dignified way, rather than being treated like literally a leper, which is what happens in so many times in Sierra Leone. So that's my answer to what are the effects and some of the needs. I know that the next part, I'm not sure if you've asked this yet, or what are the challenges. So I'll just address that now. I'm just checking.
Yeah, that's great. Thank you.
So what are the challenges at the national scale of this catastrophe? And we now see that Liberia, the rate is going down. Guinea, I think, is going down. And Sierra Leone is just going up and up and up. So that is a great challenge. What can you do with, how can you deal with this? The resistance to public health messages, the resistance to safe burials, the resistance to isolating people from each other. The challenges are the practical things like not having enough beds for the Ebola, people suffering from Ebola, but also the stigma that goes with Ebola. People would prefer to die at home than go into a hospital where they're pretty sure they're going to die anyway. And in some places, there's a high risk that if you haven't got Ebola before you go to the hospital, you will by the time you come out. So it's a really, the challenges are just, and the challenges are such, the resources are so poor in Sierra Leone anyway. So it starts from a very low base. The mental health needs in terms of psychiatric disorders are an unmet need for most of the country from what I could see. There's some secondary centres in Freetown, and this is one of the challenges that we're hoping to deal with, that we're hoping to address with our psychiatric nurses. But I think there's some questions about that in a while. Okay.
Okay, Peter. Thank you very much for that, for those responses to that, and I think that very much helps to sort of situate the discussion. Now there was an extra part to this question added on at the end, which is what is the WHO strategy on this aspect? Now, you can perhaps comment on this from your perspective. I think it's only fair that as we're sitting here in WHO, we should also comment here. I can ask my colleague Fami Hannah, who has a lot of experience working mental health and emergencies, to also respond to this part of the question. So we'll start with you, Peter, and then we'll go to Fami, please.
Okay. Well, my understanding of the strategy, which is what we were developing when we were there, and obviously a strategy can be fluid, and I might have developed since I was there, was to really invest in the human resources of the psychiatric nurses. There were 21 psychiatric nurses who've had training, and unfortunately one of them died while I was there of Ebola, of course. There's also community health officers. There's been 150 community health officers who are a sort of a basic health grade level of professional in the community, and they've been trained in mental health. So we were investing in them. So a strategy was training these people further. It was enabling the environment where nurse-led clinics could take place. It was supporting the community health officers to be able to diagnose, pick up cases in the community. It was public health about Ebola being part of this as well. A longer term or medium term strategy is about supporting mental health care as well. Other people we wanted to focus on were the survivors and how they could be such a valuable resource in terms of supporting mental health and psychosocial support. A strategy as well was to coordinate with all the other partners, and this was really impressive compared to what I've seen in other places in the past. There was a lot of work on trying to work together with the different partners in the country working on psychosocial response. So I think, yes, the other aspect of the nurses, I should say, is that these nurses and community health officers are throughout the country. So we hoped that by supporting them, that they could go to their local districts and set up nurse-led clinics or enhance psychosocial support in the local hospitals, in the communities, in the treatment centres. Thank you.
Okay, thanks, Peter. So, Fahmi, do you want to comment on or add to that, please?
Sure, Dan. Hi, everyone, and thanks for joining the mhIN webinar today. So, generally speaking, the WHO strategy in the countries affected by Ebola is focusing on providing service for people with mental illness as well as people with psychosocial problems through mainly building the capacity of general healthcare professionals as well as setting the standards for capacity buildings of volunteers and general health care professionals and social care providers as well. There's many examples for this, including what was mentioned by Peter and for example, mental health training for general health care providers using the WHO mhGAP intervention guide, designing and implementing the psychological first aid guide for Ebola and its training package. And many of these resources you can find already available at the resources repository section of the Mental Health Innovation Network website, and I encourage you to browse through these resources and download. Thank you.
Thank you. Thank you very much, Fahmi. Okay, so let's move to another question, which has already been sort of touched upon by Peter, but we'll just just clarify it. So this is around training and who has been the sort of the main target group of that training. So the question was, are primary healthcare nurses the main target group being trained, or are there also community health workers or volunteers that have been trained as well?
Okay, and I think the figure I have at the moment is we've trained about 300 people in principles of psychological first aid and communication skills, and also some aspects of mental health gap. We covered the stress module. I'm just checking if everyone can hear. Yeah,
they're all on mute, so they're not going to be able to tell you.
Okay, because it just went a bit funny here at the moment. Okay, sorry. So rather than saying primary healthcare nurses, I would say the emphasis was on the 20 psychiatric nurses who are going to go back to the districts, and the community health workers, and they were really the main aim or the main focus for our trainings. But with our trainings went much broader than that in who attended. We had all staff from primary healthcare centres, There were other nurses, there were volunteers, there were pharmacists, there were laboratory people. We had a very wide range of people attending our training. We also had a number of survivors attending our training, which was really great. And but the main ongoing work and supervision will be with those psychiatric nurses, and we hope that they can take on the mantle of leading in mental health in their area and psychosocial support, and continuing further trainings and work with those other people who are frontline health workers.
Okay, thanks. Yeah, that's very helpful clarification. So this actually leads on to the next question, which is around considering the magnitude of the impact on society. The question is, are community outreach programs on psychoeducation and awareness building a part of the training program? So maybe this is explicitly what you're referring to there. This is what the next steps is for the people who have been through the training program.
Yeah, I think that's right. I mean, at the community outreach, we really want the psychiatric nurses to have their nurse-led clinics, link with the community health workers, and see people in the community, people that may not access services so easily. Psychoeducation is a huge component of the intervention, and psychoeducation doesn't, in the context of Ebola, covers things like hand washing and safe Ebola practice. It's a much broader concept than one might think of in the West. Awareness building. I'm aware as well of the sense of the mobilization pillar, which is about public health messages. And one of the things that we were trying to do in Sierra Leone was trying to get some psychosocial messages as part of that mobilization pillar. But it all comes together. We hope that as the program develops, and it's beginning to have its first seeds at the moment, is that the public health messages, psychoeducation, and awareness all come together at a district level, starting with a nurse-led clinic and expanding into the community.
Mm-hmm. Okay, very good. Thank you very much. Now let's time's moving on, so let's open this up. So I'm hoping that you've been listening, but also thinking. And if you have a question for Peter, and this is the time to pose it. But please, to do that, please use the chat function below the list of names on the call, so towards the bottom right-hand side of the screen in front of you, and send a message to Fami, who's one of the people on the call, who will moderate and send those questions on. Fami, can I ask you whether you've received any questions, and if so, can you please relay that to Peter? Thanks.
Yes, Dan. I received one question from Elise Gehring, and the question is asking, Peter, if you or other experts from the World Health Organization are still in contact with the participants of the trainings that you have conducted in Sierra Leone, or there are any ongoing refresher courses or follow-ups on that training particularly?
Okay, I hear that question. Are there any? What is our continuing ongoing work? My understanding is that we are absolutely focusing on the psychiatric nurses, and through the psychiatric nurses, I think we will hope that there will be more ongoing refresher work, training of the community health officers, volunteers, survivors, and that will continue to happen.
Okay, good. So whilst others may be writing in their questions, I've got another one here. It relates to around alcohol consumption, and I don't know if you have a good sense of this or not, Peter. But the question is, has there been a change in the level of alcohol consumption or drug use since the start of the Ebola virus disease outbreak?
I'm aware of this question, and I've been trying to get some local information since yesterday about this, but I haven't got an answer yet. I know that when I went to the main psychiatric hospital, for example, they told me that 60% of admissions were related to substance abuse. They didn't tell me of any changes since the start of Ebola, but with substance abuse, certainly in disasters or other situations, that can be the hidden problem. And I'm hoping with some sort of community outreach that those sorts of things will be picked up. The other thing that I see as kind of like a symptom of community under stress is the rise of the increase of sexual violence. And I understand that has been an issue in Sierra Leone. I've heard stories or anecdotes about increase in sexual violence in quarantine areas. So I would be surprised if there wasn't continuing to be a major problem with drug and alcohol abuse. Whether it has increased or not from a very high baseline to start off with, I don't know. I do know, though, that if alcohol or drugs are being used, that will increase the risk of contracting Ebola.
Right. Okay, I've got one more question here, and I think, Fahmi, you may have received one more question. Is that correct?
Yes, Dan, I received a couple of questions here.
Go ahead, please.
The first question is for Peter: have any other psychiatrists traveled to Sierra Leone, and/or do you plan to return?
Okay, when I was in Sierra Leone, there was one other psychiatrist who was there already, Dr Peter, and then Dr Sedai arrived at the same time as myself, and I understand he's going back there. So there were three of us there at the time. Our contracts were for relatively short times. If I could go tomorrow, I would definitely do that, but I do have my commitments in London as well. So, but I would love to go back. It was when I was leaving that I really got the sense that things were moving on. We were working now at really trying to scale up our training, go to the districts. So it was quite frustrating to be leaving at that time. There is a lady who's taken over our role called Carmen there at the moment, I think she's a psychologist in background. So I don't think it has to be a psychiatrist, because I think it's psychosocial, so it can be, we all kind of do similar things. I think that for specific psychiatric problems, there may be a specific need for psychiatrists at some stage and some of the psychiatric aspects of those problems. But for the future, I think there's a commitment to ongoing psychosocial work, which includes psychiatrists. And would I go back? Absolutely. I stay involved with the King's Sierra Leone mental health link. And one of the projects we were trying to do there is set up a nurse-led clinic in the Connacht Hospital, in the main hospital there. So I'm still very much involved in that from a personal point of view.
Great. Peter, I still have two more questions.
Okay.
I have one question here from Fiona Shanahan, who asking a question specific to social integration of children and youth affected by the Ebola, and wants to know whether WHO has been involved in developing community-based psychosocial programs to support children and youth returning from the interim care centers.
Okay, that's a good question. I'm not so sure whether I could say WHO is doing this directly, but when I was there, we were working very closely with UNICEF, lots of other NGOs working with children and trying to support children coming out of the treatment centers or orphans And there's some absolutely horrible stories that you will hear, which I hope are getting better. Stories like children going to the treatment centers with their parents because their parents have Ebola and there's nowhere else for them to go. So there's kind of horrible things that are happening that need to definitely improve. But my answer really is that there are people doing that. WHO is part of that, but I think it's probably other organizations are leading more directly with that piece of work. And it is happening, but not enough. And I would just wonder what's happening in some of the districts, whether it's comprehensive.
Thank you, Peter. I'm still getting more questions.
Oh, okay.
One question which just came through email now, asking about, are healthcare providers and trainers working with traditional healers or religious leaders for this mentioned public health awareness campaigns or psychosocial aspects? If so, how?
Yeah, I'm not sure if I can fully answer that, because I know that traditional healers have taken a big hit from Ebola. A lot of them have died, and my understanding was that they were kind of stepping back a little bit from Ebola because they were so scared and because so many of them had died. So they are absolutely part and parcel of Sierra Leone life. And I think that probably at this stage, they really need to be brought in again. And I'm hoping again that by the psychiatric nurses working at district level and the community health officers, at a district level, they can make links to the traditional healers. They need to be part of the education as well. So they need to have safe Ebola practice. They can absolutely see people, but it has to be in a safe way. But the traditional healers are very, very important. How that happens from now, I'm sorry, I can't answer properly.
Yeah. Thanks, Peter. I still have two more questions. One question just came from Melissa Harper, is asking about what is the most important thing you have learned from your experience in Sierra Leone?
Gosh, I learned so much. I can be flippant and say, things like hand washing and how important that is in terms of Ebola. I've learned things about myself as a person. I've learned things from the resilience of the people that I've seen and the survivors, how they have just managed to have such terrible stories of so many people in their family are dead and that they carry on. I've learned a lot of stuff about Ebola itself and the resilience of the human being, I think.
Great.
Okay, that's great. So, Fahmi, do you have any more questions?
Another question which just came by email about...
This may be the last one.
Sure. So this question is asking about, is there a need to support the mental health needs of doctors, nurses, and other health professionals working with Ebola patients?
Okay, that's a really good, interesting question. And I can bring it to a very personal level. When I became a contact pretty early on, and it's really hard in Sierra Leone not to become a contact, which is that you have been in contact with someone with Ebola and are at risk of contracting Ebola. I can tell you how scared I was, and it was really nerve-wracking for a while. The way I kind of dealt with that was through psychoeducation and knowledge of Ebola. I would just take my temperature all the time. And if you don't have a temperature, you're probably okay. So that kind of helped my anxiety. I did some staff support work with people, and I did some staff support work with people who had been contacts, who had just had someone die with them. And people were really, really scared. There was lots of rumors and myths going around, such as that you could catch it, that it could be airborne, which of course is not true, that you could have Ebola and not have a temperature. And my understanding is that it's only when you have the temperature that you are infective. So I think that but the whole staff support, I just remember one staff support session. I saw that there was a lot of people with somatic complaints. They were starting to get symptoms which they thought were like Ebola. One person thought that if you had a temperature, that stress could bring on a temperature, which is the one thing that we know that is specific to Ebola. I also was checking with some people, how are your children coping? And the children are having a lot of problems. They don't have school to go to. People I was talking to say their children never say the word Ebola, but they're scared. They have bedwetting, clinging behaviors, problem behaviors. It's really affecting staff and their children. And if you're working in Sierra Leone, you're never far from Ebola. So you always are at risk. So you've always got that anxiety. So staff support sessions were really important. And what we did with a lot of our sessions is we offered to see people or follow it on. And people didn't tend to take that up. I think they just liked to know that there was someone there if they needed it.
Okay. Well, Peter, this has been really fantastic. The richness of your insights based on your first-hand experience, your recent experience there. So thank you very much again for your contribution. Thank you to everyone for joining this question and answer session organised through the Mental Health Innovation Network. We'll be doing others, and just to say that we have recorded this, so we will provide a link through the Mental Health Innovation Network newsletter or website that will be made available. Perhaps not until the new year now. We'll see how much editing it needs. But if you've missed some of this recording or wish to forward it to others, that'll be available soon. So on that note, thank you very much again, and goodbye to everyone.